We will now look at other scanner technology that allows for dose optimization. As important as any exposure factor setting for CT when optimizing dose is setting the acceptable level of noise within an image. This is the parameter at which the multidisciplinary team really comes into play. Here we are looking at adjusting how the scanner measures the quality of imaging we want to produce against other factors such as patient size and directly affects modulation. When creating a scanning protocol, it is important to know the quality that is an acceptable balance between the images being considered diagnostic and the dose received by the patient. Different manufacturers have different means of doing this. Siemens and Philips adjust the noise based on standard patients or MAS level and vary the noise. However, Canon and GE use a noise-based index. In some scanners, large patients can receive unnecessarily high doses, whereas this is not justified by the level of image quality required. This problem is probably addressed in newer models. Remember here that you would be working with your radiologist colleagues to tweak your protocols such that you have found the balance between image quality and radiation dose. This should not be a one-time task, and as software updates or scanners are changed, these settings should be reviewed to look for possible dose savings. In helical scanning, the first image can only be reconstructed at the first point in the helix, where 180 plus fan angle projections are available. Therefore, radiation is wasted until this point is achieved, and this is the Z-axis overscan. The proportion of wasted radiation is greatest in small volume acquisitions. This can be eliminated by moving the collimator blades in the Z-axis direction at the beginning and end of the scanned volume. This is referred to as collimator shutter action. Until relatively recently, CT scanners were reliant on a reconstruction algorithm called filtered back projection, or FBP. FBP is more susceptible to image noise than iterative reconstruction techniques that are commonly found on all modern scanners. FBP was favoured for many years as its relative simplicity resulted in near-live image reconstruction, whereas the complicated computation required for iterative reconstruction presented delays.
Before we talk about iterative, you need to consider what was used prior to its availability. This was the process known as filtered back projection. Actually, an iterative process was considered initially when CT was first invented, as it was able to reduce the amount of noise in an image to a greater extent than filtered back projection. The problem was that this was extremely computationally intensive, and in those days computing power was simply insufficient on a scanner to use an iterative reconstruction. Times would have been far too long. The benefit of filtered back projection is that it took far less time to reconstruct the images. Once computing power had matured to a level that made it practical to use iterative, the manufacturers introduced these new reconstruction technologies. ADA3D, which stands for Adaptive Iterative Dose Reduction, is Canon's iterative reconstruction technology.
We will now move away from scanner technology and look more closely at some other tools we can use for dose optimization, starting with the scan length adjustment. Dose length product is linearly related to scan length. This means that limiting scan length reduces dose. Limiting scan length to only cover region of diagnostic interest produces real reductions in the dose received by patients. As an example, let's think about low-dose KUB scans, of which most centres perform hundreds, if not thousands, of studies a year. This examination frequently suffers from a scan length that is greater than required. Literature states that the kidneys generally sit below the upper border of T12. Ensuring technique is correct for all scans and that the scan length does not travel further than the upper border of T12 for KUB scans will reduce the dose received by all patients undergoing this examination. A basic but often overlooked dose optimization tool at our disposal is ensuring that examinations undertaken, especially in high-dose modalities such as CT, are clinically appropriate. Radiographers working within CT should have an excellent knowledge of protocols and their corresponding clinical indications, and access to protocol folders containing these details. Clinical indications for scan protocols should be reviewed regularly in response to new evidence. An example of a change in practice for clinical appropriateness can be seen in the update to the NICE guidelines in March 2020 regarding unprovoked pulmonary emboli. Where a previously positive CTPA without known cause would mean a contrast-enhanced abdomen and pelvis should be considered, updates to the evidence base have meant that the NICE guidance has changed, and an abdomen and pelvis scan is now not indicated. What better way to optimise dose than to either direct a patient towards a different modality, or ensure that the protocol undertaken is the most appropriate for the clinical indications?
Practical ways to optimise dose in CT scanning. The first way is you need to center the patient correctly in the gantry to enable correct dose modulation. You need to use the appropriate scanning protocol for that patient. So you should be looking at the size of the patient. You could be looking at the actual area that you're actually scanning. You need to select the correct scanning protocol. You need to scan the scan length needs to be correct. You shouldn't be over scanning an area that you don't need to have on the images. One way of also that I usually do is to look at the predicted dose length product before you actually scan the patient, and to just have an idea of what the actual dose is going to be. You should also be looking at your scanning protocols with your radiologists. One way is to optimize by not only scanning once. Do we really need a non-contrast CT scan before? Can we do a scan with just a dual phase injection and only scan once? That's why we should be standardizing all our scanning protocols